I'm Dr. Zainab Vora, and today I'm going to talk to you about the Cerebellum Academy ORRs in Hyderabad. So I am very excited to see you all, and I am going to be having 2 days of sessions with you. In one half of the day, we are going to be covering radiology in a very integrated, crisp and efficient manner. In the other 1.5 days, we are going to be doing something called as BTR. What is BTR? It stands for Buri Tara Rato. So it is just a funny way of saying and compiling things which are very volatile that you need to memorize for the exam. There is just no way around it. So what we are going to be doing is we'll compile all the important stuff from all 19 subjects, stuff like lines and tubes, color coding of various instruments, parasitology, eggs, developmental milestones, IPC sections. So these are things which are going to be very factual, STI kits, biomedical waste management, things which we have to memorize. So this is one part. But apart from that, what I'm going to be doing is I'm going to take all 19 subjects, pick out the important topics which I feel, figure in every single MCQ exam that you appear for. And I'm going to be doing a very concise, efficient summary of them. So how we've placed and designed this course is such that in the last part, after you're done with the 18 subjects, we're going to be doing these 2 sessions, these 2 days of sessions in the final 2 days on 29th and 30th of December. And this will also act like a very good revision of the entire ORR itself. So let me just take you through 2 topics very quickly from neurology, which I will just show you how we are going to be revising very, very efficiently. And this is something that, you should implement when you're studying on your own also, that because we have so much syllabus to cover, you can't just go into the depths of everything. You have to be very smart about what are the questions which have come, what are the important topics, and how do you revise efficiently. So that is again something we'll be doing a lot in the session. We'll be talking about how should you study, very efficiently. How do you approach MCQs? Extremely important. What are the buzzwords that you have to, look for? And that is what I'll be stressing in these flowchart based approach that, I shall be teaching. So let's have a look. Quickly, we'll summarize, the topic of headache and stroke. 2 of the most important topics from, neurology and path per se that you need to remember, that you need to cover, and I'll show you how you can do it in less than 10 minutes. 2 topics which otherwise would take you at least a couple of hours. So let's begin. So when we're talking about headache, the kind of approach that you have to take first, look at what the examiner is saying. Is it a unilateral headache? Is it a bilateral headache? If it is unilateral headache, the first thing, is it pulsatile? Timeline 4 to 72 hours, associated with nausea or an aura. In that case, the diagnosis becomes migraine. Very quickly, drug of choice for migraine. Remember, best drug of choice for termination of migraine, it's going to be triptans. If they ask you next, always NSAIDs first, followed by triptans, right? So here, drug of choice, it's going to be triptans. If they ask you what is the drug of choice for prophylaxis, recurrent migraines are happening, prophylaxis, drug of choice becomes beta blockers, right? So here the drug of choice is going to be propranolol or beta blockers. If the unilateral headache is repetitive, occurring again and again, and it's centered around the eye, very important, focused around the eye, associated eye symptoms like lacrimation, Horner syndrome. If they tell you this kind of a headache is occurring in a male, this in itself is a buzzword because all of the other headaches are more common in females except this one, which is cluster headache. So cluster headache, repetitive headache occurs as clusters, lasts for 15 to 180 minutes. So this is cluster headache. Very quickly, the drug of choice for cluster headache, remember 100% oxygen along with triptans. This is a previous year question. So 100% oxygen with triptans to terminate the attack. If they ask you prophylaxis, that's going to be verapamil, right? Calcium channel blocker for termination. If this headache around the eye is for 2 to 30 minutes, shorter duration, and it responds to indomethacin, this is a buzzword, slightly extra edge from Harrison's. This is paroxysmal hemicrania. So here the diagnosis is something called as paroxysmal hemicrania. If the duration goes even shorter, for seconds, spasmodic pain, burning, stabbing sort of pain around the eye, this is an entity which is called SUNCT. What is SUNCT? Remember the full form? Short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. Do I already know all of this? Yes, it is short-lasting unilateral neuralgiform, conjunctival injection and tearing. So we anyways know all of it, so no need to memorize this long full form. So this entity is SUNCT. Very important differential of SUNCT is when this pain for the same spasmodic duration 5 to 200 seconds is along V2 and V3. It's triggered by chewing, talking or touching. Basically when you are triggering the trigeminal nerve V2 and V3. This entity is trigeminal neuralgia. Very important to distinguish SUNCT versus trigeminal neuralgia. This is V1, this is V2, V3. Drug of choice for trigeminal neuralgia, very important, carbamazepine. One more extra edge question, if it doesn't respond to carbamazepine, we try gamma knife. Remember, stereotactic radiosurgery, gamma knife. So this is how we are approaching this repetitive unilateral headache. If they tell you unilateral headache associated with cord-like thickening of an artery in an elderly patient, it's associated with hip girdle pain, shoulder girdle pain, symptoms which are pointing towards polymyalgia rheumatica, we are going to be thinking of giant cell arteritis or temporal arteritis, all right? One more specific symptom, jaw claudication. So this is how, very quickly we focus on buzzwords, things which are going to actually turn up in the exam, and do not beat around the bush and reach the topic. So this is how you have to study from now on when we are near the exam. Okay. If the headache is bilateral, two things. If it is band-like 4 to 6 hours, one of the most common type of headaches, this is tension headache, right? Something that we all have, tension headache, bilateral band-like headache. Here, what is the drug of choice? Here, the drug of choice is going to be nothing but NSAIDs. However, for prophylaxis, what do you want to give? For prophylaxis, drug of choice is TCA, particularly amitriptyline. Okay. On the other hand, very important, they give you a female who's having dull aching pain with papilledema, symptoms of raised intracranial tension, and you get these risk factors in the form of a TOAD. What is TOAD? One, the female is taking tetracyclines. Second, OCPs or obesity. A for vitamin A excess and D for danazol. So these are the 4 risk factors associated with this entity. Tetracycline, O for OCPs, obesity, A for vitamin A, D for danazol. Here you have to consider idiopathic intracranial hypertension or pseudotumor cerebri. So this is IIH or pseudotumor cerebri. One hint they will give you is in the form of MRI, where they show you that the optic nerve sheath is distended. There is papilledema, optic nerve sheath distension on MRI. They are pointing towards IIH. Treatment, terminate the risk factors. If it doesn't respond, acetazolamide or a VP shunt or an optic nerve fenestration. Release the pressure, right? So this is what is going to be the quick summary of headache in less than 5 minutes. We've covered this very, very important topic. Do you want to do one more in 5 more minutes? Let's hope we get questions from these itself. So here, stroke, extremely important. When do you suspect a stroke? So this is fast, something that every layman also needs to know. So remember, anytime you see facial drooping, arm weakness, speech difficulty or slurring of speech, and T for time, time is brain, it's an emergent condition, you need to call the EMS, the emergency medical services, very quickly. So this is the mnemonic FAST, which is something that is now being made aware to the public a lot, that they need to be aware of these signs of stroke, so that we do not waste any time in taking the patient to the hospital, because remember, time is brain. We have to act very, very quickly. Okay, so FAST is the mnemonic, but for any medical purpose, remember, any acute non-reversible focal neurological deficit is stroke unless proven otherwise. So acute focal neurological deficit is stroke. What do you do next? The moment the patient comes, the first thing you have to do, remember in the flow chart, a non-contrast CT scan. NCCT is the first investigation of choice, doesn't take time, readily available. NCCT, our main aim is to rule out hemorrhage. How does hemorrhage appear on CT? It appears hyperdense, it appears white. So if I see that there is hemorrhage, rule out this patient. This patient is a neurosurgical candidate. I am not managing him with my flow chart right now. So we've ruled out white hemorrhage. Now anything, whether the CT shows me these findings or the CT is normal. If there is no hemorrhage, it is ischemic stroke unless proven otherwise. Okay. So what are the signs that you may see on CT? On CT, I might see this subtle hypodensity, which is representative of the edema, or this specific sign wherein the MCA appears white, which is called as dense MCA sign, which is suggestive of an acute thrombus in the MCA. So you may or may not be given these findings. They might just tell you CT is normal. If CT is normal, means there is no hemorrhage. Now I have to see whether patient is in window period or not. Again, this is something that keeps getting updated. This is what current Harrison says. 4.5 hours is the window period that we will accept. If from the onset of symptoms there is passage of less than 4.5 hours, the patient, we have to take him up for IV thrombolysis. We first have to rule out any contraindications. If there are no contraindications to thrombolysis, patient is in window period, start IV thrombolysis. So contraindications very quickly: BP more than 185 by 110, bleeding diathesis, head injury or intracranial hemorrhage, major surgery in 2 weeks, GI bleed in 3 weeks, and recent MI. So these are the contraindications. They will usually tell you in the exam that there are no contraindications to thrombolysis. What do you do next? If patient is in window period, IV thrombolysis. One more concept. What if the patient slept off at 10 o'clock and just woke up with the weakness? What is the time that we consider? For that, we use a concept called LSW. When was the patient last seen well? Means if the patient went to bed at 10 o'clock when he was normal, that is the time that I will consider for my window period, which is last seen well. I will not count from when he woke up. I will count from when he was last seen well. Remember this. If the patient is in 4.5 to 6 hours, a new concept, an extra edge concept. If he is not in window period, but still it's less than 6 hours, can I still offer him something? Yes. So for this, we can still offer him treatment, but there are two prerequisites. To see those requisites, I need an investigation, which is CT angiography plus CT perfusion. Repeat INI CT question. We will do a CT angio and a perfusion. Why? First, I want to see whether a major artery stroke is there. I can pick it up on CT angio. I want to see whether there is penumbra or not. P for penumbra, P for CT perfusion. Remember, that is the only investigation that tells you penumbra, perfusion study. What is penumbra? It is an area which is still not infarcted, but it is ischemic. So this is the salvageable area. If you open it, there is still hope that that area will be spared. Okay. So if I find on those studies that there is thrombus of a major artery with penumbra, I can offer him intra-arterial treatment. Intra-arterial thrombolysis, not IV. We go into the artery with an endovascular approach. We can offer intra-arterial thrombolysis or mechanical thrombectomy. So here interventional radiology will come into play. We can offer these treatment. But if no penumbra, no major artery thrombus, we can't really do anything for these patients. Okay, so this is how we are going to approach stroke, and this is a very high topic that we've covered, you know, in around 15 minutes in total. We've discussed everything that we wanted to. So I hope this has been productive, and this just gives you a brief idea or a brief trailer into what these 2 days are going to be like. So stay tuned and see you all. Very excited to see you all in person. So Hyderabad, we are coming. All the very best and take care.